A very good day to everyone. I'm Zerking, and today me and my teammates Fanyi, Kishan, and Yutesh will be presenting about the viral infections of the oral cavity. Our learning objectives are explain clinical and microscopic features of viral infections and list the investigations for diagnosing these diseases. Our list of viral infections of the oral cavity include human herpes virus, human simplex virus, varicella zoster virus, cytomegalovirus, enterovirus, rubella, mumps, and HIV. So I'll be presenting first. My topics include HHV, HSV, and COVID-19, which will be explained before the ending of this presentation. Next, I'll be talking about the human herpes virus. The human herpes virus family constitutes a large family of double-stranded DNA virus. The best known member of this family is HSV, or otherwise known as herpes simplex virus, which includes HSV type 1 and HSV type 2. Other members of the HSV family include varicella zoster virus, Epstein-Barr virus, cytomegalovirus, and more recently discovered members such as HSV 6, 7, and 8. Humans are the only known natural reservoir for these viruses, which are endemic worldwide. Moving on to herpes simplex virus. So they are mainly divided into HSV1 and HSV2. The two herpes simplex viruses are similar in structure and disease mechanisms, but they differ in antigenicity, anatomic site predilection, and epidemiology. HSV1 spreads predominantly through infected saliva or active perioral lesions and adapted best to oral, facial, and ocular areas. The pharynx, intraoral mucosa, lips, eyes, and skin above the waist are most involved frequently. Genital HSV1 infections are uncommon, although recent studies have shown an increase in the proportion of genital herpes caused by HSV1 in developed nations. This trend has been attributed to an increase in oral genital sexual behavior and lower rates of non-sexual HSV1 acquisition in childhood. HSV2 is adapted best to the genital zones and is transmitted predominantly through sexual contact and typically involves the genitalia and skin below the waist. Oral and pharyngeal infection with HSV2 is also possible but occurs infrequently. The clinical features include acute herpetic gingival stomatitis, which is the most common clinical feature seen, herpes labialis, intraoral recurrent herpetic infection, and herpetic whitlow. Next, I'll be talking about the microscopic features of HSV. HSV-infected epithelial cells will exhibit acantholysis, nuclear clearing, and nuclear enlargement. The acantholytic epithelial cells may be referred to as Zang cells. Nucleolar fragmentation occurs with a condensation of chromatin around the periphery of the nucleus. Multinucleated epithelial cells are formed by fusion between adjacent cells. Intercellular edema develops and leads to the formation of an intraepithelial vesicle. In addition to that, mucosal vesicles rupture rapidly. Those on the skin often persist and become infiltrated by inflammatory cells. Once they have ruptured, the mucosal lesions demonstrate a surface fibrinopleural membrane. Often at the edge of the ulceration or mixed within the fibrinous exudate are the scattered Zang or multinucleated epithelial cells. So as we can see in this picture provided, the Zang cells are exhibiting ballooning degeneration, margination of chromatin, and also multinucleation. The investigations of herpes simplex virus include viral isolation from tissue culture inoculated with the fluid of intact vesicles, cytologic smear and tissue biopsy, direct immunofluorescence, and PCR, which is also known as polymerase chain reaction.
My name is Fanny and I'll be talking about varicella zoster virus, cytomegalovirus, and enterovirus. And I will start off with varicella zoster virus. Varicella, also known as chickenpox, has the following clinical features. In immunized individual, it represents breakthrough infection, which means infection with wild-type virus in a previously immunized patient. So we can see macular papilla, cutaneous rash with small number of lesions, low or no fever, shortened disease course of 4 to 6 days. Patients are contagious until no new lesions appear within a 24-hour period. In unimmunized individuals, there will be malaise, pharyngitis, rhinitis, and in older children and adults, additional symptoms such as headache, myalgia, nausea, anorexia, vomiting will be there. And the rash begins on the face and the trunk and spread to the extremities. The stages of lesion begin with erythema, vesicles, pustule, hardened crust, and each vesicle is surrounded by a zone of erythema and has been described as a dewdrop on a rose petal. In contrast to herpes simplex, the lesions typically continue to erupt for 4 or more days, and affected individuals are contagious 2 days before exanthum until all the lesions crust, and fever is usually present during the exanthum phase. Perioral and oral manifestations of varicella are fairly common and may precede the skin lesions. The most common site is on vermilion border and palate, followed by buccal mucosa and gingiva. It is painless. The lesion begins as 3 to 4 mm white opaque vesicles that rupture to form 1 to 3 mm ulceration. Oral ulcerations numbering up to 20 and may persist for 5 to 10 days. The microscopic features for varicella is acantholysis with formation of numerous free-floating zinc cells which exhibit nuclear margination of chromatin and occasional multinucleation. The investigation for varicella include viral cytopathologic effects present within epithelial cells harvested from vesicular fluid, and we can perform PCR on vesicular fluid cells from the base of a lesion or a scab from a resolving skin lesion. We can also demonstrate a fourfold or greater increase in varicella zoster viral antibody titers between acute and convalescent serum samples. However, this is not preferable in vaccinated persons. I'll move on to herpes zoster, also known as shingles. There are 3 phases in herpes zoster known as prodrome, acute, and chronic. Ganglionitis develops with resultant neuronal necrosis and severe neuralgia. Pain intensifies as virus travel down the nerve. It is described as burning, tingling, itching, boring, prickly, or knife-like. Pain develops in area of epithelium innervated by the affected sensory nerve, dermatome, and may be accompanied by fever, malaise, and headache. Thoracic dermatomes are affected in about 2/3 of the cases. This prodromal pain normally precedes the acute phase rash by 1 to 4 days. Acute phase begins when the involved skin develops clusters or vesicles set on an erythematous base. Lesions tend to follow the path of the affected nerve and terminate at the midline. Within 3 to 4 days, the vesicles become pustular and ulcerate, and crust develop after 7 to 10 days. The lesions are contagious until they crust. Exanthum typically resolves within 2 to 3 weeks. The oral lesions of herpes zoster occur with trigeminal involvement. It may present on the movable and bound mucosa. Lesions often extend to the midline and frequently accompanied by involvement of the skin overlying the affected quadrant. Lesions manifest as 1 to 4 mm vesicles that rupture to form shallow ulcerations. Teeth in affected area may show pulpitis, pulpal necrosis, pulpal calcification, or root resorption. Significant bone necrosis with tooth loss has also been documented. The microscopic features of herpes zoster are identical to those seen in primary infection, varicella. Herpes zoster is often diagnosed from clinical presentation. Its investigation include viral culture, rapid diagnosis using direct staining of cytologic smears with fluorescent monoclonal varicella zoster viral antibodies, PCR, and dot blot hybridization. Next, cytomegalovirus, also known as human herpes virus 5. Cytomegalovirus infection is asymptomatic in 90% of the cases. However, in clinically evident congenital and neonatal infection, there will be jaundice, hepatosplenomegaly, cutaneous erythropoiesis, and thrombocytopenia. and CNS involvement includes microcephaly, seizures, mental and motor impairment, and there will be non-hereditary sensory neural hearing loss. Among immunocompetent individuals, it exhibits as infectious mononucleosis-like presentation to lethal multi-organ involvement. CMV mononucleosis manifests as fever, chills, sore throat, headache, and fatigue. And other symptoms of CMV infection include joint and muscle pain, abdominal pain, non-productive cough, maculopapular rash, and diarrhea. Oral manifestations of CMV infection are chronic oral ulceration that is associated with HIV infection and other immunosuppressive conditions. Neonatal CMV infection can produce developmental tooth defects. The teeth exhibit diffuse enamel hypoplasia, significant attrition, enamel hypomaturation, and yellow coloration from underlying dentin. Microscopic features of cytomegalovirus infection. Biopsy specimens of intraoral CMV lesions may demonstrate changes within vesicular endothelial cells or salivary duct epithelial cells. Scattered infected cells are extremely swollen, showing both intracytoplasmic and intranuclear inclusions and prominent nucleoli. These enlarged cells are called owl-eye cells. Pus stains demonstrate the cytoplasmic inclusion but not the intranuclear changes. Investigation for CMV include tissue biopsy to demonstrate cells with viral inclusions which suggest CMV infection, immunohistochemistry, in situ hybridization, serology, ELISA, viral culture, and polymerase chain reaction. Next, I'll talk about enteroviruses, which are further classified into echoviruses, Coxsackie viruses A and B, and polioviruses. Enteroviruses primarily affect children 1 to 4 years old. In Herpangina, there will be acute onset of sore throat, dysphagia, and fever. Occasionally, it is accompanied by cough, rhinorrhea, anorexia, vomiting, diarrhea, myalgia, and headache. Most cases are mild or subclinical. Small number of lesions, 2 to 6, develop on the soft palate and tonsilla pilus in the oral cavity. Lesions begin as red macules which form fragile vesicles that rapidly ulcerate, and ulcerations average to 2 to 4 mm in diameter. Systemic symptoms resolve within a few days and ulcerations will take 7 to 10 days to heal. Hand, foot and mouth disease is best known presentation of enterovirus infection. Skin rash and oral lesions typically are associated with flu-like symptoms such as sore throat, dysphagia, fever, and occasionally by cough, rhinorrhea, anorexia, vomiting, diarrhea, myalgia, and headache. Oral and hand lesions almost always present. Oral lesions of hand, foot, and mouth disease arise without prodromal symptoms and may precede the cutaneous lesions. It resembles those of Herpangina but may be more numerous and more frequently involve the anterior regions of the mouth, and the number of lesions ranges from 1 to 30. Buccal mucosa, labial mucosa, and tongue are the most common sites, but any area of oral mucosa may be involved. Individual lesions measure 2 to 7 mm in diameter but may be larger than 1 cm. And the lesion typically ulcerate and heal within 1 week. Cutaneous lesion of hand, foot, and mouth disease range from a few to dozens. It primarily affects the borders of the palms and soles, ventral surfaces and sides of the fingers and toes. It rarely includes the buttocks, external genitals, legs. Lesions begin as erythematous macules that develop central vesicles and heal without crusting. In some cases, nail loss or ridges may ensue after several weeks. Acute lymphonodular pharyngitis is seen in enterovirus infection. It is characterized by sore throat, fever, and mild headache which may last from 4 to 14 days. Low numbers, 1 to 5 or below, to dark pink nodules develop on the soft palate or tonsilla pilus. The nodules represent hyperplastic lymphoid aggregates and resolve within 10 days without vesiculation or ulceration. Microscopic features of enteroviruses. In Herpangina and hand, foot, and mouth disease, the affected epithelium exhibit intracellular and intercellular edema which lead to formation of an intraepithelial vesicle. The vesicle enlarges and ruptures through the epithelial basal cell layer with formation of subepithelial vesicle, and epithelial necrosis and ulceration will soon follow. Inclusion bodies and multinucleated epithelial cells are absent. Enterovirus is usually diagnosed based upon clinical manifestation, and the investigations include viral isolation from culture, serologic demonstration, or rising enteroviral antibody titers between acute and convalescent stages. PCR assay can also be done.
Hi, my name is Kishan. I'll be explaining about measles and rubella. First of all, I'll start with measles. Measles is also known as rubeola, is a highly contagious infection produced by a virus in the family Paramyxoviridae and genus Morbillivirus. It is a primary respiratory infection. Transmission is through direct contact with respiratory secretions and aerosols. Now I'll move on to the clinical features. The incubation period of measles is an average of 14 days. It is infectious from 4 days before symptomatic and till 4 days after the appearance of rash. Most cases of measles arise in late winter or spring. The virus is associated with significant lymphoid hyperplasia that often involves the lymph nodes, tonsils, adenoids, and Peyer's patch. The adenoid is also known as pharyngeal tonsils or nasopharyngeal tonsils, whereas Peyer's patch are small masses of lymphatic tissue found throughout the ileum region of the small intestine. There are 3 stages of infection, with each stage lasting 3 days, hence it is named 9 days measles. Common oral manifestations of measles occur on the buccal mucosa. The first 3 days are dominated by the 3 C's: coryza, cough, and conjunctivitis. Coryza is the inflammation of the mucous membrane of the nose, causing runny nose. Cough is typically brassy and uncomfortable, and conjunctivitis causes red, watery, and photophobic eyes. These are usually accompanied by fever. During this initial stage, the most distinctive oral manifestation, Koplik spots, is seen. These lesions represent foci of epithelial necrosis and appear as numerous small blue-white macules or grains of salt surrounded by erythema, which can be appreciated in the diagram. Typical sites of involvement include the buccal and labial mucosa and less often the soft palate. As the second stage begins, the fever continues, the Koplik spots begin to fade, and a maculopapular and erythemus mobiliform rash begins. This can be seen in the picture below. The face is involved first, with eventual downward spread to the trunk and extremities. Ultimately, a diffuse erythemus eruption is formed, which tends to blanch on pressure. In the third stage, the fever ends. The rash begins to fade with downward progression and replacement by brown pigmentation. Ultimately, discoloration of skin is noted in areas previously affected by the rash. The oral manifestations of measles are not only Koplik spots. There is also presence of candidiasis, acute necrotizing ulcerative gingivitis, and necrotizing stomatitis, which may occur if significant malnutrition is present. Severe measles in early childhood can cause pitted enamel hypoplasia of the developing permanent teeth. There is also enlargement of accessory lymphoid tissue such as lingual and pharyngeal tonsils. Now I'll be explaining about the microscopic features. Koplik spots represent areas of hyperparakeratotic epithelium with spongiosis, dyskeratosis, and epithelial syncytial giant cells. The number of nuclei within these giant cells ranges from 3 to more than 25. On close examination of the epithelial cell often reveals pink staining inclusion in the nuclei, or less commonly cytoplasm. Electron microscopy has shown that the inclusion represent microtubular aggregates characteristic of paramyxovirus infection. As the spot ages, the epithelium exhibits heavy neutrophilic exocytosis leading to microabscess formation, epithelial necrosis, and ultimately ulceration. There is also presence of multinucleated giant lymphocyte cells, which have been given the term Warthin-Finkeldy giant cells. The area circled in the histological picture below shows the multinucleated giant cells, also known as Warthin-Finkeldy giant cells. Now I'll be explaining about the lab diagnosis. First of all, IgM antibodies assay can be performed on a single serum sample. The antibodies usually appear within 1 to 3 days after the beginning of the exanthem and persist for 1 to 2 months. Confirmation by rising IgG titer, viral culture, and reverse transcription polymerase chain reaction (PCR) are also possible. Demonstration of multinucleated giant lymphocyte cells, also known as Warthin-Finkeldy cells, in Giemsa stained smears of nasal secretion can also be done. Now I'll be explaining about rubella. Rubella is also known as German measles. Rubella is a mild illness caused by a virus in the family Togavirus and genus Rubivirus. The greatest importance of this infection lies not in its effect on those who contract the acute illness, but in its capacity to induce birth defects in the developing fetus. The infection occurs primarily in late winter and early spring. The mode of transmission is through contact with respiratory droplets. Infection of mother with rubella during pregnancy can cause congenital rubella syndrome. Now I'll be explaining about the clinical features of rubella. The incubation period of rubella is 12 to 23 days. Patients infected with rubella are contagious from 1 week before to 1 week after the onset of the exanthem. Infants with congenital infection may release the virus for up to 1 year. Prodromal symptoms may be seen 1 to 5 days before the exanthem and includes fever, headache, malaise, anorexia, myalgia, mild conjunctivitis, coryza, pharyngitis, cough, and lymphadenopathy. The lymphadenopathy may persist for weeks and is noted primarily in the suboccipital, postauricular, and cervical chains. The rash is often the first sign of infection and begins on the face and neck, with spread to the entire body within 1 to 3 days. The exanthem forms discrete pink macules, then papules which finally fade with flaky discomation. Facial involvement often clears before the rash completes its spread to the lower body areas. Generally, the rash completely resolves by day 3, hence it is called 3 days measles. The oral manifestation of rubella is Forchheimer sign. This lesion consists of small discrete dark papules that develop on the soft palate and may extend onto the hard palate. This arises simultaneously with the rash, becoming evident in about 6 hours after the first symptom and not lasting longer than 12 to 14 hours. There is also presence of palatal petechia. Now I'll be explaining about the microscopic features. The microscopic features of rubella are presence of inflammatory infiltrate accompanied by hemorrhage, which can be seen in the diagram below, and also presence of apoptotic hepatocyte, which can be seen in the arrow pointed. The diagnosis of rubella is dependent on laboratory tests because the clinical presentation of the acquired infection is typically subclinical, mild, or non-specific. Serological analysis is the mainstay of diagnosis. First of all, there is fourfold rise in rubella IgG antibodies titer between the acute and convalescent serum specimen. There is also positive serological test which indicates specific IgM antibodies. There is also positive rubella culture by isolation of the rubella virus. Finally, polymerase chain reaction (PCR) can also be done to diagnose rubella. Thank you.
Hi, my name is Yutesh and I'll be explaining about mumps and also HIV today. So first of all, mumps. The causative agent or family of mumps is Paramyxoviridae. The genus of mumps is Rubella virus, and the transmission of mumps is usually through respiratory droplets, saliva, and also urine. And the incubation of mumps is usually around 16 to 18 days, which is around 2 to 3 weeks. So next we'll be moving on to the clinical features of mumps. So what is mumps? Mumps is basically the swelling of the salivary glands. mainly affecting the parotid gland. The prodromal symptoms may be seen one day after significant salivary changes, which are low-grade fever, headache, malaise, myalgia, nausea, vomiting, and also anorexia. So mumps is basically swelling and discomfort in the major salivary glands. The enlargement and pain typically peaks within 2 to 3 days, and chewing movement of the jaw tends to increase the pain. An enlargement of the gland usually begins on one side, followed by contralateral involvement within a few days. The second most common finding is epididymoorchitis, which occurs in about 25% of post-pubertal males. So what is epididymoorchitis? The testicles exhibit rapid swelling with significant pain and also tenderness. If left untreated, testicular atrophy may also occur. And lastly, spontaneous abortion may occur approximately in 25% of women who contract mumps during the first trimester of pregnancy, which is the first 3 months of pregnancy. Next, we'll move on to the oral manifestation of mumps. The most frequently reported oral manifestation is redness and enlargement of the Wharton and Stenson salivary gland duct openings. Usually, mumps occurs in the parotid gland, and the swelling will be unilateral, which is one side of the face. But involvement of the sublingual glands may produce bilateral enlargement of the floor of the mouth, as you can see in the picture below. Mumps usually occurs in the parotid gland. So the microscopic features of swollen parotid glands include diffuse interstitial edema and an inflammatory infiltrate composed of histiocytes, lymphocytes, and also plasma cells. The picture on the right shows an electron microscopic feature of the swelling. Lastly, the lab diagnosis of mumps. Usually mumps can be made easily from a clinical presentation, but the most frequently used diagnostic procedure is demonstration of either mumps-specific IgM or a four-fold rise of mumps-specific IgG titers between the acute and also convalescent phases. In addition, a swab of secretion obtained from parotid or other affected salivary gland ducts, for example like the sublingual gland, can be used for viral culture or real-time reverse transcription PCR testing. So next we'll be talking about HIV. HIV is also known as human immunodeficiency virus. So the family of HIV is known as Retroviridae, and there are two types of HIV, which is HIV-1 and also HIV-2. HIV-1 is basically the worldwide distribution responsible for majority of the cases, which is known common to us. And HIV-2 mostly occurs in Africa, mostly the east side of Africa. And the transmission of HIV is through sexual transmission and also infected body fluids such as blood and breast milk. And the most important thing is HIV cannot be transmitted through saliva. Infected needle between drug abusers is also a common way of transmission of HIV. The clinical features of HIV can be divided into two parts, which is the seroconversion illness and also symptomatic HIV. Seroconversion illness occurs 2 to 6 weeks after exposure. Patients may experience a non-specific flu-like illness, for example, fever, muscle ache, malaise, pharyngitis, maculopapular rash, and also lymphadenopathy. The maculopapular rash is the most common clinical features for HIV. And over the next months or years, the infection can enter a later asymptomatic phase. Next is the symptomatic HIV clinical features. So after a latent phase, the HIV infection will become asymptomatic, where the patients may experience weight loss, high temperatures, diarrhea, and also frequent minor opportunistic infection, for example like herpes zoster or candidiasis. Next, we'll see the oral manifestations of HIV. So oral manifestation of HIV can be divided into two parts, which is the oral candidiasis and also periodontal lesions. So under oral candidiasis, there are 4 types. The first one is pseudomembranous candidiasis. This clinically appears as a white to yellowish white plaques which can be easily scraped off. exposing red areas. It may also extend to involve the oropharynx and esophagus. And this oral pseudomembranous candidiasis usually occurs in the tongue and also on the buccal mucosa. Next is angular cheilitis. Angular cheilitis is the redness at the angle of the lip. Next, under oral candidiasis, there is also erythematous candidiasis. This is clinically seen as a red lesion which are commonly located on the dorsum of the tongue, palate and also buccal mucosa. Tongue lesions are also referred to as central papillary atrophy. And lastly, there is also hypoplastic candidiasis. This lesion is characterized by white plaques which cannot be removed by scraping, and this is usually seen on the lateral border of the tongue. Next, we move on to the periodontal lesions of HIV. So the first one is lineal gingival erythema, which is also known as LGE. It's a non-plaque induced gingivitis exhibiting a distinct erythematous band of the marginal gingiva with either diffuse or punctuate erythema of the attached gingiva. Next is chronic periodontitis. This is mainly common in HIV patients. So chronic periodontitis has also been reported with an increased rate of attachment loss or exacerbated periodontitis. And the last periodontal lesion under oral manifestation for HIV is necrotizing periodontal diseases, which is subclassified as necrotizing ulcerative gingivitis, NUG, necrotizing ulcerative periodontitis, NUP, and also necrotizing stomatitis, NS. So NUG involves destruction of one or more interdental papilla and is limited to the marginal gingiva. NUP extends beyond the papilla and also marginal gingiva, causing the loss of the periodontal attachment. When the necrosis extends beyond the periodontium into the mucosa and osseous tissue, it results in NS, as you can see in the above picture. The microscopic features of HIV can be seen by using the periodic acid shift stain, which is also known as PAS stain. By using this stain, we can see that there's numerous fungal organisms embedded in the superficial keratin. And oral epithelium exhibiting hyperparakeratosis and layer of balloon cells in the upper spinous layer can be seen. There's also epithelial cells demonstrate nuclear beading, can be seen in the picture below. Lastly, the lab diagnosis of HIV. So the most famous method of diagnosis of HIV is using ELISA and also Western blot method. So primary test ELISA, which stands for enzyme-linked immunoabsorbent assay, is used to detect HIV infection. If an ELISA test is positive, the Western blot test is usually administered to confirm the diagnosis. If an ELISA test is negative, but you think you may have HIV, you should be tested again in another 1 to 3 months, because the HIV takes time to actually produce its symptoms. The next one is viral load test. This test measures the amount of HIV in your blood. It's used to monitor treatment progress or detect early HIV infection. 3 technologies measure HIV viral load in the blood, which is reverse transcription polymerase chain reaction, RT-PCR, branch DNA, bDNA, and also nucleic acid sequence-based amplification assay, NASPA. HIV is detected using DNA sequences that bind specifically to those in the virus. Thank you. Now I'll be passing the presentation back to Zaking to continue with coronavirus.
Thank you, Yudesh. So we have an additional note which is about COVID-19, and I'll be presenting it. So I'll be presenting about coronavirus. Coronavirus, which is also known as COVID-19, is an infectious disease caused by a newly discovered coronavirus. Most people infected with the COVID-19 virus will experience mild to moderate respiratory illness and recover without requiring special treatment. Older people and those with underlying medical problems like cardiovascular diseases, diabetes, chronic respiratory disease, and cancer are more likely to develop serious illness. The best way to prevent and slow down transmission is be well informed about the COVID-19 virus, the disease it causes, and how it spreads. Protect yourself and others from infection by washing your hands or using an alcohol-based rub frequently and not touching your face. At this time, there are no specific vaccines for the COVID-19 virus. However, there are many ongoing clinical trials evaluating potential treatments. As dentists, a few precautions are to be taken during dental health care. This includes isolation of the patient, adequate room ventilation, respiratory protection such as N95 masks, and postponing of non-emergency dental procedures. Next, wear a surgical mask and eye protection with solid side shields or a face shield to protect mucous membranes of the eyes, nose, and mouth. Surgical masks are also one use only, and one mask should be used per patient. Any damaged mask or if breathing through the mask becomes difficult should be removed, discarded safely, and replaced with a new one.
And lastly, this is our link to our Socrative. You can do our questions there, try out our questions, and this is our references. Thank you.